Good morning and welcome all to our second day of pre-licensing training. We're thrilled to have everybody back and maybe even a few newcomers. So I'm going to quickly go through the announcements. I'm going to try to keep it brief because we've got a chock full session this morning. But just remember to leave your conference link open. It will be used for both of the sessions today. If for some reason you close it, you can go to coveringwisconsin.org and find the link or go back to your email. All attendees are on mute and will remain on mute throughout the session. If you have a question, please type it in the questions and answer box. We will take strategic breaks throughout the session for questions. Mostly we will be looking at them after we do the polling questions, the interactive polling questions. And today there will be an opportunity for you to see the questions asked by others and vote up the questions that you would like answered. So please use that function if you see a question that you definitely want to hear the response to. Please be sure to participate in the interactive polling questions during each session. It's okay if you're not confident in your answers. We're just looking for active participation. And here's a reminder that pre-licensing certificates will be issued later in September to attendees who attend all 6 pre-licensing sessions and all regular conference sessions. And then once you have that certificate, you will be eligible to sit the navigator exam. And a quick reminder that there will be 2 special opportunities after the conference ends that you might be interested in joining. On Friday, October 1st from 9 to 10, there'll be general office hours hosted by Adam Van Spinkeren to answer questions and just discuss anything that was presented in the conference that you're curious to learn more about or have questions about. And then later that morning at 10:30 a.m., I will be hosting an exam study session for anyone who wants to just spend a little extra time preparing for the Wisconsin Navigator and Certified Application Counselor licensing exam. So without any further ado, I'd like to introduce our first presenter today. So we welcome Nikki Biddick, who is a program and policy analyst, as well as an enrollment and outreach coordinator at the Wisconsin Department of Health Services. Nikki has over 20 years of experience working with elderly, blind, and disabled Medicaid policy and programs. We're excited to welcome Nikki to her inaugural pre-licensing training and look forward to learning about consumer eligibility for elderly, blind, and disabled, also known as EBD Medicaid programs in Wisconsin. Take it away, Nikki.
Thank you. All right, I need to share my screen here, so let me get that going. And I just want to make sure, is everyone able to see my screen?
Yes.
Yep.
Wonderful. All right. Thanks again, Shannon. Again, I'm Nikki Biddick. I'm here to talk to you about elderly, blind, or disabled, or EBD Medicaid today. I will say EBD is a lot. I know it's a lot. We're going to do our best to get you the most information we can in the amount of time we have here this morning. So we will get to as many of your questions as we can today. And without further ado, we'll get going. So the agenda for today includes going over the purpose of this training, an overview of Medicaid, including the non-financial and financial rules, as well as the sub-programs of Medicaid. I know Rachel mentioned this yesterday, but I do want to again provide you with some information about those COVID-19 temporary rules that are currently in place. Temporary changes have been made to Medicaid policy during the federal public health emergency, including maintenance of eligibility for existing members, postponement of renewals, changes to verification requirements, suspension of premiums, suspension of the work requirement for MAP, and the addition of elderly, blind, and disabled adult population to presumptive eligibility. Again, that's presumptive eligibility, not presumptive disability. The information provided in this training today does not include these temporary rules. For example, you're going to hear me talk about a work requirement when we get to the MAP information. Due to the temporary rules in place, there is no work requirement for MAP at this time. However, we wanted to provide you with the rules as they normally are and will be, as far as we know, once the COVID-19 public health emergency ends. So the purpose of this training is to provide navigators, certified application counselors or CACs, partners, agents and brokers with an overview of the eligibility rules for EBD Medicaid programs. And as a reminder, you discussed applying for Wisconsin's healthcare programs and eligibility rules for Badger Care Plus yesterday with Rachel. So we won't be talking about how to apply for EBD Medicaid since you did already discuss that yesterday. Medicaid for the elderly, blind, or disabled, or EBD Medicaid, covers adults age 65 and older and individuals who have been determined blind or disabled by the Disability Determination Bureau, or DDB. Many people often confuse Medicaid with Medicare. Medicaid is a joint federal and state program that provides high-quality healthcare coverage, long-term care, and other services to over 1 million Wisconsin residents and is the topic of our conversation today. Medicare is a health insurance program administered by the federal government. It's divided into 4 parts. Part A provides coverage for hospitalization and skilled nursing facilities. Part B covers such things as doctor's visits. Part C, which is Medicare Advantage, that's a supplemental coverage sold by private companies, and you might have heard that Part C also being referred to as Medigap. And Part D, which provides prescription drug coverage. Again, Medicaid and Medicare, 2 different programs, and we're discussing Medicaid today. So let's first look at an overview of EBD Medicaid eligibility rules. As Rachel mentioned yesterday, please keep in mind that this training provides an overview of the eligibility factors that will be considered for EBD Medicaid. It's not intended as a training on how to actually determine eligibility. Only income maintenance, or IM, agencies and workers can determine eligibility for most programs. More information about specific programs and policies can be found in the Medicaid Eligibility Handbook, or MEH, which you can find by following the first link shown on this slide. I do recommend you get familiar with the MEH and the Badger Care Plus handbook. That will help you, I think, in the long run. The policies described in this training are subject to change. Updates are available a couple of ways. The second link shown on this slide is a biweekly stakeholder call series hosted by DHS to provide information about eligibility policy updates and rule changes affecting Wisconsin programs such as food share and Medicaid. The last link on this slide, which I believe was also given yesterday, takes you to a site where you can sign up to receive email updates regarding DHS programs and services. So full benefit EBD Medicaid includes many different programs. So we're going to start by giving you some basic information, and then we'll get into detailed information about each one in just a bit. Supplemental Security Income, or SSI Medicaid, is for people who are getting federal supplemental security income, or SSI payments. Individuals receiving SSI are automatically eligible for Medicaid and don't need to apply for Medicaid through the IM agency. SSI related Medicaid is the basic EBD Medicaid program for people who are age 65 or older, blind or disabled, but who are not getting SSI. A Medicaid deductible allows people who are above the income limit for SSI related Medicaid to become eligible for Medicaid after they have met a deductible. Special status Medicaid is for people who once received SSI but no longer do, and with a special disregard, still meet the criteria for Wisconsin's SSI-related Medicaid. Medicaid Purchase Plan, or MAP, is for individuals with a disability who are working or want to work. The Katie Beckett program is for children with disabilities who require an institutional level of care. Well Woman Medicaid is for women under age 65 who need treatment for breast or cervical cancer or certain precancerous conditions. Institutional Medicaid is for elderly, blind, or disabled people who are living in a nursing home, hospital, or other institution. And home and community-based waivers help elderly, blind, or disabled people live in their own homes or in the community rather than in an institution. Now, there's also some limited benefit Medicaid programs. Individuals eligible for these programs have limited coverage, not full benefit coverage. Emergency services covers services needed for the treatment of an emergency medical condition if the individual meets all program rules except for qualifying immigration status. Senior care is a prescription drug assistance for individuals who are age 65 and older. The Medicare savings programs help individuals enrolled in Medicare pay their Medicare premiums, deductibles, co-pays, and/or co-insurance. So again, Medicare is that health insurance program administered by the federal government, has parts A, B, C, D, not Medicaid. But the Medicare savings programs are Medicaid programs that can help people pay some of their Medicare costs. And we're going to talk about that more in detail in a bit. So let's take a look at some of the basic non-financial and financial rules for EBD Medicaid. Individuals must be elderly, which is 65 or older for Medicaid, or have been determined blind or disabled by the Disability Determination Bureau to be eligible for EBD Medicaid. They must be a Wisconsin resident, which means they must be physically present in the state with an intent to continue residing in Wisconsin. They must also be a citizen or qualifying immigrant. Individuals must provide a Social Security number with a few exceptions. They must supply the required information and verification within the required time frame. And they must pay premiums or cost sharing if they are required by the specific program. Most EBD Medicaid subprograms have an income limit and an asset limit, but those do vary by program, and we're going to get into those details. Some income limits are fixed amounts, while others are based on the federal poverty level, or FPL. FPL is a federally determined income amount that is scaled based on household size and is usually adjusted every year. Current FPL amounts for EBD Medicaid can be found at the link shown on this slide. And most subprograms count the income and assets of the member and his or her spouse. Now, there are some exceptions that apply to children with disabilities, though. Children are not subject to an asset test, and in some cases, parents' income is not counted or is only partially counted. Countable income for EBD Medicaid includes, but isn't limited to, gross earned income, self-employment earnings, Social Security income, retirement benefits, unemployment insurance, income from trusts, interest and dividend income, child support, and alimony. Income types and rules are outlined in the Medicaid Eligibility Handbook, or MEH, Chapter 15. Countable assets for EBD Medicaid include, but aren't limited to, cash, checking and savings accounts, stocks, bonds, and CDs, non-home real property, some vehicles, some trusts, some life insurance policies, some burial assets, some annuities, some loans, and some reverse mortgages. And again, asset types and rules are outlined in MEH Chapter 16. There are also some allowable deductions for EBD Medicaid, and those do vary by subprogram, but all EBD Medicaid programs do allow a $20 standard deduction, as well as a 65 1/2 earned income deduction. The 65 1/2 earned income deduction is calculated by removing $65 from the household's earned income, then deducting half of what's left. For example, if someone has $1,065 per month in earned income, $65 would be deducted, leaving $1,000. Half of $1,000 is $500. So the total deduction would be $565. And the countable earned income would be $500. There are subprogram specific deductions as well. So depending on the subprogram being determined, some examples of those subprogram specific deductions include support payments, court-ordered attorney or guardian fees, impairment-related work expenses, and medical and remedial expenses. And we're going to take a closer look at some of those subprogram specific deductions when we take a closer look at those programs in a bit. This brings us to our first poll question. So we are gonna get that full question up on the slide here. Wonderful. All right. Which of the following individuals may be non-financially ineligible for EBD Medicaid based on the information given? So which of these individuals may be non-financially ineligible? Janice, a 44-year-old who has been determined disabled by DDB, Edgar, age 68, Penelope, age 70, living in her home in Minnesota, or Ricardo, a 24-year-old who has been determined blind by DDB. Which of these individuals do you think may be non-financially ineligible for EBD Medicaid? And we're going to give you some time to do that.
5 more seconds to answer, and then we'll close it out. Oh, everybody's answered. Okay.
Oops, I lost the poll for some reason. There we go. All right, it looks like a majority of you answered Penelope, age 70, living in her home in Minnesota. That is the correct answer. Janice has been determined disabled by DDB, so she could potentially be eligible. Edgar is 68, which is 65 and above, and Ricardo has also been determined blind by DDB. So they all have, those three, A, B, and D, are either disabled or elderly, so they can potentially be eligible. Penelope does not live in Wisconsin, is not residing in Wisconsin, so she would potentially be ineligible. She would be ineligible for EBD Medicaid in Wisconsin. Great job, you guys. All right. Any questions that have come in so far that we need to answer before we move on to the next?
Nope, go ahead.
Okay, sounds good. All right, now that we've talked about the basic non-financial rules for EBD Medicaid, let's take a closer look at each of the sub-programs in more detail. First, let's talk about SSI Medicaid. The federal SSI program provides cash benefits to people who have little to no income or assets, who are 65 or older, blind, or disabled. SSI has income and asset limits similar to those used for EBD Medicaid. In Wisconsin, if someone qualifies for the federal SSI payment, they also will receive the state SSI payment. Also, if someone's getting SSI payments, they automatically qualify for SSI Medicaid. This means they don't have to apply for Medicaid separately, and their eligibility for Medicaid is not determined by the IM agency. SSI Medicaid is a full benefit Medicaid program. Now let's talk about SSI related Medicaid. This is different than SSI Medicaid, which again was that Medicaid someone gets when they get those SSI payments. They're automatically eligible for SSI Medicaid. Although the coverage for both of these programs is the same since they are both full benefit Medicaid programs. SSI related Medicaid is the basic EBD Medicaid program for people who are elderly or blind or disabled as determined by the Disability Determination Bureau, or DDB, but who are not receiving SSI. Eligibility for this program is determined by IM agencies. The income limit for this program is 100% of the federal poverty level, or FPL. For one person, that amount is currently $1,073.33. And for a couple, 100% of the FPL is currently $1,451.67. SSI related Medicaid is outlined in MEH Chapter 24. SSI related Medicaid also does have an asset limit. For a single individual, countable assets must be below $2,000, and for a married couple, countable assets must be below $3,000. If someone is over the income limit for SSI related Medicaid, they can become eligible for SSI related Medicaid by meeting a deductible. Deductibles are often also referred to as spend downs. Deductible rules are also outlined in MEH Chapter 24, and Medicaid deductibles are calculated for a 6-month period by removing 100% of the FPL from the total countable monthly income and adding those 6 remainders together. And again, 100% of the FPL for one person is currently $1,073.33. So for example, if a single person's countable monthly net income was $1,173.33 for each month of their deductible period, and the income limit didn't change for any of those months, they would be $100 over the income limit for each month, and their total deductible amount then would be $600. There are several ways to meet a deductible. Individuals can submit unpaid and recently paid medical bills to meet a deductible. They can choose to prepay the deductible in order to obtain coverage, or they can have a combination of unpaid or recently paid medical bills and prepayment. Information about how to meet a deductible is outlined in MEH 24.7. Once a deductible is met, the individual is eligible for full benefit Medicaid coverage, and Medicaid pays for covered services from the point the deductible is met until the end of the 6-month deductible period, at which time a renewal would be due. Here's an example. Bobby is a single 68-year-old with total countable income of $1,500 per month. She applies for healthcare in July and is over the income limit for SSI-related Medicaid, so the IM agency calculates a deductible period for her from July to December. Again, that period is 6 months. Since Bobby's income was the same for all 6 months, and since the income limit also remained the same for all 6 months, the total amount she is over the income limit for each month won't change and is $426.67 for each month. So the total amount of her 6-month deductible is $2,560.02. This is the amount she must meet before she can be eligible for Medicaid. On July 6th, Bobby has outpatient surgery and has unpaid medical bills totaling $3,500 from the procedure. She submits proof of these bills to the IM agency to meet the deductible. By meeting the deductible, she becomes eligible for Medicaid from July 6th, the date she incurred the bill, until the end of December, the end of her deductible period. Now, she is going to be responsible for the portion of the bill used to meet the deductible. So the deductible amount, remember, was $2,560.02. She's still going to owe that to the hospital because that was the amount of her deductible. But Medicaid will cover the rest, the $939.98, as long as the bill was for services that are covered by Medicaid, also known as covered services. Covered services are outlined in MEH 21.4. This brings us to our next poll question. Which of the following is not a true statement for SSI-related EBD Medicaid? The asset limit for a single person is $2,000 per month. SSI-related Medicaid deductibles are set up for a period of 6 months. The income limit for SSI-related Medicaid is 100% of the federal poverty level. Or D, the only way to meet a deductible is to prepay the amount. So which of the following is not a true statement for SSI-related EBD Medicaid? Awesome. That is, looks like most of you answered correctly. D was the correct answer. The asset limit for a single person is $2,000 a month. Deductibles are set up for a period of 6 months, and the income limit for SSI-related Medicaid is 100% of the federal poverty level. There are several ways that people can meet the deductible. They can prepay, but they can also provide medical bills. So D was the correct answer for this question. I do also want to, I see there was a question, and it was, looks like it is being answered, but I do just want to touch on that. The question was, an elderly person that wants to apply for Medicaid, will his children's income be considered if the elderly person doesn't work and is a widow? And then the answer to that is a child's income is not counted for the EBD parent's eligibility determination. Kids are not even in a fiscal test group for EBD Medicaid. If they were applying for Badger Care Plus, this CARES Worker Web System would determine eligibility for Badger Care Plus first. And if the EBD, the parents, were not eligible for Badger Care Plus, actually the system would look for EBD Medicaid first for a parent, but EBD households or EBD fiscal groups are always a group of 1 or 2. So when we're looking at eligibility for an applicant and they are an EBD member, we are looking at them by themselves unless they have a spouse in the home. So going back, we have one more question. Is Medicaid funded by local governments too, in addition to federal and state? I'm not sure of the answer to that one. So I am going to have to defer. I don't know, do Maciel, do you or Rachel know the answer to that one at all?
I Googled it, and it says that authorized under the Social Security Act, Medicaid is jointly financed by federal, state, and local governments, including counties.
Okay, thank you, Maciel. So the answer is yes, it is funded by local governments too. All right. Next, let's talk about the Medicaid Purchase Plan, or MAP. MAP is a Medicaid subprogram. It's a full benefit Medicaid program, and it is determined by IM agencies. MAP is for individuals with a disability who are either working or enrolled in a health and employment counseling program. The program has higher income and asset limits to allow members to get healthcare coverage while they are employed. MAP information, including information about the Health and Employment Counseling Program, or HEC, can be found in MEH Chapter 26. As a reminder, the work requirement for MAP is currently being waived due to the temporary COVID-19 rules. The income limit for MAP is 250% of the FPL based on a household that includes the member's spouse, and the member's minor dependent children. Stepchildren are not included in the household size for the applicant. So for example, if Fred was applying for MAP for himself only and his household included himself, his spouse's minor child with someone else, and a minor child in common, Fred would be a household size of 3, himself, his spouse, and the child in common, because stepchildren are not included, and his income limit would be $4,575 per month. Now, the member and their spouse's net income is used to compare to the income limit for the household size. So for Fred, his household size was 3, so his and his spouse's income would be compared to that income limit for a household size of 3 to determine if Fred was eligible for MAP. MAP does allow that $20 standard deduction and the $65.50 earned income deduction that we talked about earlier. It also allows an impairment-related work expense deduction, a special exempt income deduction, and a medical and remedial expense deduction only if the applicant and spouse have med remedial expenses that total more than $500. If they have med remedials that total less $500 or less, none of them are allowed in the eligibility determination. If they have more than $500 combined in med remedial expenses, the entire amount above $500, or the entire amount, would be allowed. If they had $525 total in med remedials, all $525 would be allowed as a deduction in the eligibility determination for MAP. Premiums for MAP are charged based on the member's income only. If the member's gross income exceeds 100% of the FPL for a group of 1, and currently that amount is $1,073.33, then a premium will be charged. As a reminder, premiums are currently being waived due to the temporary COVID-19 rules we discussed at the beginning of the presentation. Finally, the asset limit for MAP is $15,000, and only the member's assets are counted. So, household size includes the member, his or her spouse, and minor children of the member only. Net income, which you use to compare to the household size, includes the member and his or her spouse's income with allowable deductions. Premiums, when we're charging premiums, are charged based on only the member's income, and again are currently being waived, and only the member's assets are counted. Long-term care Medicaid programs include institutional Medicaid, as well as home and community waivers programs such as family care partnership, include Respect I Self-Direct, also known as IRIS, program of all-inclusive care for the elderly, also known as PACE, which is available in Milwaukee and Waukesha counties only, and Children's Long-Term Support Program, also known as CLTS. Institutional Medicaid is Medicaid for elderly, blind, or disabled individuals who are living in a nursing home, hospital, or other medical institution. Eligibility for this program is determined by IM agencies. Now, the individual must have either resided in a medical institution for 30 or more consecutive days, or be likely to reside in a medical institution for 30 or more consecutive days, as attested to by the medical institution, in order to be eligible for institutional Medicaid. Medical institutions include, but are not limited to, hospitals, skilled nursing facilities, intermediate care facilities, and in some cases, institutions for mental disease. When someone applies for healthcare and indicates that they're in an institution or need institutional care, this is considered an application for institutional Medicaid. Financial rules for institutional Medicaid include eligibility and cost sharing are determined based on income, assets, the cost of care for the medical institution, and other qualifying expenses. For a single individual, the monthly income limit is $2,382, but they may also qualify if their income is less than their cost of care plus other expenses. For a single individual, the asset limit is $2,000. Some income and assets may be allocated to the applicant's spouse and/or minor children, and divestment penalties may apply to people who sell or give away income or assets for less than their fair market value. And divestment is a period of ineligibility due to giving away income or assets. Home and community waivers programs help people live in their own homes or in the community rather than an institution. So individuals must be eligible for a full benefit Medicaid program or long-term care waiver Medicaid to be enrolled into a home and community waiver program. Individuals must meet a certain level of care called a nursing home level of care as determined by the Aging and Disability Resource Center, or ADRC. So individuals must contact the ADRC for enrollment counseling and to have their level of care determined. The ADRC will help to identify the most appropriate home and community waiver program for the individual. Again, if the individual is already eligible for full benefit Medicaid, the ADRC can go ahead and enroll that individual into the appropriate home and community waiver program. If the individual is not already eligible for full benefit Medicaid, the individual must submit a Medicaid application to the IM agency. Generally, the ADRC is going to help them do that. To find an ADRC in your area, you can follow the link on this slide. Long-term care waiver Medicaid is a specific form of full benefit Medicaid used to enroll individuals in a home and community waiver program when they are not eligible for any other form of full benefit Medicaid. Individuals must be elderly, blind, or disabled to be eligible for long-term care waiver Medicaid. Remember, on the last slide, we said individuals already eligible for full benefit Medicaid could be enrolled in a home and community waiver program by the ADRC. But if they weren't already eligible, a Medicaid application would need to be submitted to the IM agency. So the IM worker then determines eligibility for Medicaid when they get that application. They check for all other full benefit Medicaid programs first. And then if the individual is not eligible for any of those, CWW or Cares Worker Web, the system that IM workers use, will check for long-term care waiver Medicaid. The financial rules for long-term care waiver Medicaid are very similar to the rules for institutional Medicaid, including that some income or assets can be allocated to the applicant's spouse and/or minor children, and the fact that divestment penalties may apply to people who sell or give away income or assets for less than their market value. All right, this brings us to poll questions 3 and 4. So we'll bring up poll question 3. Oh, okay. When determining eligibility for Medicaid Purchase Plan or MAP, which of the following is not true? MAP has higher income and asset limits than SSI related EBD Medicaid. Assets of everyone in the home are counted for MAP eligibility. When determining if a MAP premium will be charged, only the member's income is counted. When determining the MAP household size, stepchildren are not included. So when determining eligibility for MAP, which of the following is not true? I'm happy to address that question, Michael, here in just a little bit after our poll questions. It's a great question.
And we'll give this first poll question just another 10 seconds or so, and then we'll move on to the next one.
Wonderful. B was the correct answer. It looks like most of you chose that one, 75% of you. Great job. So when determining eligibility for Medicaid Purchase Plan, assets of everyone in the home are not counted. Only assets of the applicant are counted for MAP eligibility. Great job. All right. Poll question number 4. Which of the following is not true for institutional Medicaid? Medical institutions include, but are not limited to, hospitals, skilled nursing facilities, and intermediate care facilities. B, for a single individual, the asset limit is $2,000. C, some income and assets may be allocated to an applicant's spouse and or their minor children. Or D, to be considered institutionalized, the individual must have resided or be expected to reside in a medical institution for 60 or more consecutive days. Which of the following is not true for institutional Medicaid? Wonderful. Yes, the correct answer is D. Which of the following is not true? To be considered institutionalized, the individual must have resided or be expected to reside in a medical institution for 30 or more consecutive days, not 60 or more. Great job. All right, let's go ahead and answer the question we have before we move on. So likely to be institutionalized for 30 days. Does this mean that an individual admitted in the middle of July, but determined then to need institutional care for 30 days, may be eligible to get eligibility for July rather than waiting for August? Yes, that's absolutely what it means. If someone is going into a nursing home or an institution and it's expected that they're going to be there 30 days or more, they should apply right away. They should definitely apply right away. I mean, because if they're expected to be there for 30 days or more, the IM worker will determine eligibility for institutional Medicaid. The other thing is I want to mention is that the 30 days does include any institution, anything that's considered a medical institution. So say someone was in the hospital for 15 days and they went directly from the hospital to the nursing home and they were in the nursing home for 15 days. The total of those two are 30 days. That is considered institutionalized. They could potentially be eligible for institutional Medicaid for both the hospital and the nursing home. The only time you can't add those together is if there's a break in between. So if someone was in the hospital for 15 days, then went home and then went to an institution, That going home breaks that up, and you can't use that as the consecutive days. Any other questions before we move on? I want to make sure we get to. We can also come back at the end. I think we might have time. This is going better than I even thought. This is wonderful. Okay, moving on. All right, let's talk about Medicare savings programs in a little more detail again. So again, as a reminder, Medicare is not Medicaid. Medicare is that health insurance program run by the federal government, has 4 parts, A, B, C, and D. IM agencies don't determine eligibility for Medicare. Medicare savings programs are Medicaid programs. They are limited benefit Medicaid programs, not full benefit Medicaid programs, that help individuals who are enrolled in Medicare pay their Medicare premiums, and in some cases, their Medicare deductibles, co-pays, and or co-insurance. Excuse me. IM agencies do determine eligibility for Medicare savings programs. Now, you might hear these programs referred to simply as MSP, Medicare Savings Programs. Sometimes you might hear them referred to as Medicare Premium Assistance, or MPA, or for those of us that really want to reveal how old we are, you might sometimes hear them referred to as buy-in. There are 4 types of Medicare savings programs. The first is Qualified Medicare Beneficiary, also known as QMB or QMB. To be eligible for QMB, the individuals must be entitled to Medicare Part A. The income limit is 100% of the FPL for a group size of 1 or 2. And the asset limit is $7,970 for a single individual and $11,960 for a married couple. If someone is eligible for QMB, QMB Medicaid pays their Medicare Part A and Part B premium, as well as Medicare deductibles, co-pays, and co-insurance. Also, QMB is the only Medicare savings program where the member will get a forward health card if they're eligible, so that they can use that to pay for those Medicare deductibles, co-pays, and co-insurance. That can sometimes confuse members. They think because they have a forward health card, they must be eligible for full benefit Medicaid. Quite honestly, I think sometimes it confuses doctors' offices as well. But that is not true. If they only have QMB eligibility, that forward health card is only helping to pay those Medicare deductibles, co-pays, and co-insurance. All right. Some Medicaid members are automatically eligible for QMB. People eligible to receive SSI are automatically eligible for QMB. So people receiving SSI, remember, are automatically eligible for Medicaid, so they don't need to submit an application to IM for the Medicaid, and they're also automatically eligible for QMB, so they don't need to submit an application to IM for Medicare savings programs either. QMB is like the Cadillac of the Medicare savings programs. Some Medicaid members who once received SSI but no longer do are automatically eligible for QMB as well, including 503 assistance groups and disabled adult child or DAC assistance groups. Both of those are special status Medicaid groups, and you can find out more about them in MEH 25.1 and 25.2. The next Medicare savings program is Specified Low-Income Medicare Beneficiary, also known as SLMB or SLIMB. And in order to be eligible for SLIMB, the individual must be currently getting Medicare Part A. The income limit is 120% of the FPL. And the asset limit is $7,970 for a single individual and $11,960 for a married couple. If someone is eligible for SLIMB, SLIMB Medicaid will pay their Medicare Part B premiums only. The next Medicare savings program is Specified Low Income Medicare Beneficiary Plus, also known as SLMB Plus or SLIMB Plus. In order to be eligible for SLIMB Plus, the individual must be currently getting Medicare Part A. The income limit is 135% of the FPL. The asset limit is $7,970 for a single individual and $11,960 for a married couple. And the individual may not be enrolled in any other Medicaid program, full or limited benefit Medicaid program, and be eligible for SLIMB Plus at the same time. If someone is eligible for SLIM Plus Medicaid does also pay their Medicare Part B premiums. So the difference between SLIM and SLIM Plus is that SLIM Plus has a higher income limit, and individuals eligible for any other form of Medicaid, full or limited benefit, can't also have SLIM Plus. Individuals eligible for any other Medicaid can have other Medicaid and Quimby and other Medicaid and SLIM, but not other Medicaid and SLIM Plus. The final Medicare Savings Program is Qualified, Disabled, and Working Individual, also known as QDWI or QDWI. And in order to be eligible for QDWI or QDWI, the individual must be under age 65 and disabled. The individual must have lost premium-free Medicare Part A as a result of returning to work. The member cannot be eligible for any other Medicaid. The income limit is 200% of the FPL, and the asset limit is $4,000 for a single individual and $6,000 for a married couple. If someone is eligible for QDWI Medicaid pays their Medicare Part A premiums. I will tell you that I, in all my years as an IM worker, never saw a QDWI eligible person. It doesn't happen very often. Normally, Medicare Part A, it doesn't have a premium. But if someone may qualify for QDWI, actually what happens is the Social Security Administration sends a request to the IM agency or consortium asking them to check this person's eligibility for QDWI. And again, I didn't see one of those in my whole time as a worker. So let's talk about some other sub-programs. Emergency Services is a limited benefit Medicaid program that covers services needed for the treatment of an emergency medical condition when someone meets all EBD Medicaid program rules except qualifying immigration status. So emergency services is for individuals who are not citizens and don't have a qualifying immigration status. Emergency services not available for childless adults, which are adults aged 19 through 64 who are not living with and caring for a child under age 19. It's not for children with higher incomes or women enrolled in the Badger Care Plus prenatal program. Emergency services applications are processed by IM agencies, and more information about emergency services can be found at the link shown on the slide. The Katie Beckett program is a full benefit Medicaid program for children with disabilities who are living at home and require an institutional level of care. Applications are processed by the Department of Health Services, not by the IM agency. And more information about Katie Beckett can be found in the link shown on this slide. Well Woman Medicaid is a full benefit Medicaid program for women under age 65 who need treatment for breast or cervical cancer or certain precancerous conditions. Eligibility is based on enrollment in the Well Woman Screening Program or Family Planning Only services, so no separate income or asset test applies. Applications are processed by the Department of Health Services, not by IM agencies, and more information about Well Woman Medicaid can be found at the link shown on this slide. Senior Care is a limited benefit Medicaid program and provides prescription drug assistance for individuals who are age 65 and older. Applications are processed by DHS, not by the IM agencies, and more information about Senior Care can be found at the link on this slide. That brings us to our last poll question. And it looks like we've got some good questions in the comment section as well, so we'll get to those. Which of the following program is not a full benefit Medicaid program? SSI related EBD Medicaid, Medicaid Purchase Plan or MAP, Medicare Savings Programs or MSP, or Well Woman Medicaid? Which of those programs is not a full benefit Medicaid program? All right, we've got a kind of a 50-50 here. So Medicare Savings Programs are not a full benefit Medicaid program. Well Woman Medicaid, we can go back to that slide. is a full benefit Medicaid program for women under age 65 who need treatment for breast or cervical cancer or certain precancerous conditions. So while Women Medicaid is a full benefit Medicaid program, MSP or Medicare savings programs are not, none of them, QMB, Slim B Plus, or QDWI, none of them are full benefit Medicaid programs. All right, I've got a couple of additional resources, and then we're going to go ahead and answer some more questions. So online policy resources such as policy manuals, handbooks, forms, and directories can be found by following the first link on this slide, and the specific link for the Medicaid eligibility handbook is also shown here as the second link on this slide. Finally, if you're unable to find the answers you're looking for using the policy resources that have been provided by Rachel yesterday for Badger Care and by myself today for EBD Medicaid, you can direct policy-related questions regarding Medicaid and Badger Care Plus to the Forward Health Partners inbox by using the link on this slide, and I believe this was given yesterday as well. So, good news is we've got time for some questions. I am actually going to end the slideshow, and that way we can answer these questions for you.
Great. Thanks, Nikki. We're going to go back to an earlier question that was somewhat addressed in the chat first, if you don't mind. And that question is, can you explain a bit more what it means to be entitled to Medicare? Is that different than enrolled?
So let me look up the subprogram here, because I know that there have been questions about this recently and some So for QMB, they have to be receiving Medicare Part A. For SLMB, they have to be receiving Medicare Part A.
So they must be enrolled.
That's what this says, but then MEH 32.2.2 talks about being entitled, but the actual policy doesn't show entitled, it shows receiving. So I think, and Slim B Plus also says be receiving Medicare Part A. This is one that I think I would like to take back and provide an answer later on, because I know that there have been some issues with that lately that are currently being addressed as far as getting people enrolled in Medicare savings programs. So I don't want to misspeak. I am always happy to answer questions, but I'm never going to give you an answer that I think might be wrong. So I think we should take that one back and just talk about the entitled versus receiving issue. And then we will send that response back to you so that you can get that out to all the members if that works.
Yeah, that's great. Thank you for that diligence. So next up we have, do all MSPs allow Medicare late enrollees to enroll in Medicare outside the open enrollment period and without penalties?
MSPs allow Medicare late enrollee. And to enroll in Medicare outside the open enrollment period without penalties. So I think you're talking about Part B enrollment via the Medicare Savings Program's buy-in program. So members who are receiving Medicare Part A coverage, but who previously chose not to enroll in Part B, may be eligible to enroll in Part B outside of their usual enrollment periods via the MSP process with the state. So do all MSPs? It appears so, because 32.1.5 says members who are receiving Medicare Part A coverage, so they would have to be receiving Part A. But if they chose not to enroll in Part B, they might be eligible to enroll in Part B outside of their usual enrollment period. So usually if they don't enroll in Part B and they enroll later, there's the premium is higher. But if they may be eligible to enroll in Part B outside of their usual enrollment period via the MSP process with the state. So that also gives us a link to process help because it tells workers how to process it. But yes, it appears the answer to that is yes, but only if they're already receiving Part A. They would have to be eligible for one of the MSP programs in order to enroll via that buy-in.
Great, thank you. So here is a great question. So when in doubt, complete an application and a person will be enrolled in the highest level of Medicaid they are entitled to. Is that a good idea?
Absolutely, absolutely. That is
Love it.
basically,
Yeah,
yes,
that's the take home here.
that is basically what happens. The IM worker processes it, and CWW will also always look for the highest level of benefit that the person can potentially be eligible for.
Great. Okay, next up. If you qualify for Well Woman Medicaid, can you also get covered for services like dental and vision?
Anybody know the answer to that question, Rachel or Maciel? I do not have a lot of experience with Well Woman
My
Medicaid.
understanding that it's limited to the treatment that they need. It is a limited benefit.
Oh, so before
So
maybe
it's not a full benefit
misspoke.
Medicaid?
It's not a full.
It's my understanding it's a limited benefit, but that one I'm taking back just to verify.
Okay,
Okay.
I'm
Great.
just looking
So-
it up here too.
And then there was a second part to that where that is the Well Woman Medicaid program time limited?
I'll add it to the question.
Yeah.
Okay.
What I'm seeing in the MEH, and I'm sorry, I'm looking away from the screen because I have a few screens going here. In MEH 36.1, it says that as long as the woman is enrolled in Well Woman Medicaid, Wisconsin Well Woman Medicaid eligibility, she does not have to reapply. Oh, a woman must be enrolled. Okay. Yep, we're going to take that back.
Okay. Great. Okay, next up. Can we highlight the differences between the Well Woman program versus Well Woman Medicaid? I have found these program names, since they are essentially the same, really confuse people. Yeah.
Yep.
a
So
good
I
point.
think that's all. I think that's another one we'll take back unless Maciel or Rachel has the answer off the top of their head. Because I do think that it sounds like there's a lot of Well Woman Medicaid questions. And so maybe we can just bundle those all up together and send a response.
Just for clarification for those attending, I think we should bundle them up and send a full response.
Mm-hmm.
Yes. Okay, so just stay tuned for that response. It'll come via email and probably be posted to the conference website at a later date. So great questions. This is a confusing topic. Okay, let's see.
Other questions before? Any other questions about any of the other programs, MAP, EBD Medicaid, institutional, waiver Medicaid?
I'm not seeing anything else. There was a little discussion about Wisconsin Well Woman Medicaid and and the other program, but like we said, we'll share a more detailed response there. But Michael Russ did post to a DHS publication that people can click if they want to sort of look at it in the near term.
Wonderful.
So we'll give people maybe 30 more seconds to type in a question if they have one. We're just 2 minutes over time, and then we'll go to break. So any final lingering questions out there? think we were able to answer a lot by typing and also throughout the webinar, so that was great.
Wonderful.
So I just really want to share my appreciation for your time this morning, Nikki, as well as Maciel and Rachel for being on to answer questions. Oh, we got one more. I was looking at the Well Woman Medicaid as not a full Medicaid plan because it doesn't cover a lot. Oh, that's an old one. Never mind. So we're gonna go back to the Well Woman questions separately. So thank you all for attending. We will be back at 10:15 with 2 staff members from the Office of the Commissioner of Insurance to continue the pre-licensing training. Thank you all for your participation and your questions. Thank you, presenters. Remember, you can just leave this link open and come back to your desk or your computer at 10:15, walk around, get some coffee, take a little break from your screen so everybody's ready to pay attention for another great webinar in just a little bit over 10 minutes. Thanks all.
Thank you again.
Thank you, everybody.
Okay, good morning and welcome back. We are delighted to continue with today's pre-licensing conference sessions. I hope everybody made it back. Next up, we have a presentation from the Office of the Commissioner of Insurance. And that includes Shelley Knorr and Julie Walsh, which are both staff at the Office of the Commissioner of Insurance. And they will be discussing preliminary insurance rules and regulations and concepts. Shelley Knorr is an insurance examiner at the Wisconsin Office of the Commissioner of Insurance. We're pleased to have Shelley join us this year during the pre-licensing conference to teach us some fundamentals of insurance. And Julie Walsh is the senior attorney at the Wisconsin Office of the Commissioner of Insurance. And we're pleased to have Julie join us yet again at this year's pre-licensing conference. So thank you, ladies, and take it away. Julie, we cannot hear you.
How about now? Is that better?
Now we can hear you. Thank you.
Thank you very much. The double unmute. We're very excited to have this opportunity to work with you today and introduce to you today some basic concepts that we deal with insurance and some of the powers and duties of our office. Shelley and I are going to split the slides about halfway through. Tomorrow, kind of foreshadowing, we'll be dealing more with specifically health insurance and then the ACA and navigators. Today, what we're trying to do is give you a little groundwork about both who we are and what we do and the role and how they overlap with what you're going to be doing. So we're very excited that you're here and taking this training. And I'll start with the first slide, which is our home slide, just our introductory page. The next slide, please, is, and I think you have control, Shannon. Is that correct? There we go. So the mission of the Office of the Commissioner of Insurance is to protect and educate Wisconsin consumers by maintaining and promoting a strong insurance industry. I know that might sound a little odd, but how we are achieving a safe environment for our consumers is by having a strong, well-regulated insurance industry. This is how OCI is going to achieve goals and strategies, how we formulate our policies and procedures, all to further this goal. Next slide. So this is a new slide and kind of fun, and I'm not sure. Yep, great. One of the things that people don't realize is just the breadth of what we do. The picture is our Commissioner Afablia on site. But one of the things that we do is I don't know if you knew, but there are over 176,000 licensed insurance agents who can work in the state of Wisconsin. Those are not all based in Wisconsin. They may be non-resident agents, but they are also those who are resident agents. We handle over 12,000 inquiries a year about insurance-related topics on all lines. We have sent over to the school fund almost $73,000 in forfeitures or fines. So if we fine a company or an agent, that money does not stay with us, but goes to our general fund in the schools. And we recovered through helping consumers over $4.5 million. So helping resolve complaints, consumer inquiries that there was questions on how their claims were handled on any of the lines of insurance. And this is what we do. We help facilitate appropriate resolutions, especially when there has been a company or an agent that may not have fully complied with the Wisconsin laws and regulations. We were created in 1870. And what is interesting is one of the first things that existed was actually property and casualty insurance. So our history is filled with insurance and how it touches different parts of our lives. The next slide, please. So OCI, I'm just making adjustments on my screen. Thank you. OCI, as I said, was created in 1870. And we have had the same goals, although our mission statements obviously are revised with each administration. But what we try to do is achieve the best means possible to balance consumer needs, the industry's ability to function and be competitive. So we try to kind of balance a three-legged stool a bit. OCI performs a variety of tasks that are intended to protect consumers and ensure this competitive marketplace. The major functions that we undertake at OCI include reviewing actual insurance policies that are sold to Wisconsin consumers to make sure they meet our requirements, conducting examinations of domestic and foreign, so in this case, foreign would just be not based in Wisconsin, insurers to ensure compliance with Wisconsin laws and regulations. There are some very unique laws for Wisconsin, and we'll highlight those as they come up both in general insurance and then more specifically in health. We monitor the financial solvency of licensed companies to make sure that consumers have insurance coverage that they expect to have. So we're making sure these companies are solvent and able to pay their claims timely. We issue licenses not just to insurance companies and agents, but also the kind of the ancillary parts that touch insurance. So administrators, they can be either called in our state employee benefit plan administrators, or what you might be used to hearing is more of a third-party administrator. But now we are also licensing pharmacy benefit managers. We assist consumers, obviously, with our complaint process, and Shelley will be highlighting that later. We research special insurance issues to understand their impact on the state. So any federal changes, any federal laws or regulations, any things that are going on in the legislature, we're monitoring new proposals to see how they may affect or impact consumers and our insurers. We also we do technical assistance on drafting legislation and promulgating administrative rules in order to interpret the laws. So a lot of our administrative rules, the goal is to translate, but to also sometimes give better structure to what the statutes lay out. We create and distribute public information and consumer education pieces to educate consumers about the various types of products. We have really good consumer product publications, and we'll give you a link in through our base website where you can find those publications. And it's actually a pretty friendly site for word searching a topic that you might like to see. We also operate a life insurance fund, a patient's compensation fund, which is medical malpractice, sitting on top of everyone's primary layer of medical malpractice in the state. So OCI is kind of complex, but yet it works very well together and has effectively regulated the industry and protected consumers for many years. Next slides. So how do we do this? We are protecting and educating the public through doing outreach, consumer outreach. We do that by actually regulating the insurers and the agents. We monitor their conduct. We do that through the complaint system in part, because we can't be where every agent and every insurer is functioning within the state. We rely on complaints from consumers. We rely on complaints from providers. We rely on insurers and agents actually complaining on each other, because it gives us an insight into how they're functioning out in the public, and then seeing how they apply the policies and forms that we have reviewed. How are they actually using them with the public? Is it how we read them, or is it somehow different? And that would be concerning for us. What can the commissioner do? Our commissioner actually has, by statute, a fair amount of authority and power. We can administer and enforce the insurance laws of the state of Wisconsin. The commissioner must act promptly as possible on all matters placed before the office. The commissioner must possess all powers that are specifically granted or reasonably implied in the statutes. So if we feel there is power and we can justify it and authority for us to intervene, we will. This enables the office to perform the duties necessary to enforce the laws. And we do that through administrative hearings, as you'll see on a future slide, but also in adopting rules. The commissioner is required to actually examine all domestic insurers, so insurers that are originally licensed in the state of Wisconsin. At least every 5 years, we do a full financial evaluation. We obviously are seeing financial information quarterly on all of our companies and making sure that they are solvent. Next slide. So how do we do this? The powers that we have, what we use are we administer and enforce the insurance laws and regulations. We do that through issuing orders or warning letters, or we will actually do hearings. So we have the right to issue corrective action orders, corrective action plans. We'll go through administrative hearings, and that includes with our navigators as they are licensees. That will make sure that the laws are complied with. We will do full investigations with staff like Shelley for health to really figure out what the concern is from the consumer, what the actions were from the consumer and the insurance company, and try to figure out if there's been compliance with insurance laws. The orders that we issue can be both just respond to us, or they can be fix a specific situation. They can include fines or forfeitures. They can include requirements to report and respond to us or the consumer. Or we may actually take, more frequently, agents' licenses for those who are not following the laws. We require licensees, so all licensees, navigators and intermediaries or agents and companies, to respond to our inquiries, and that's actually a statutory requirement. They must respond. They must provide us what we ask for. There's usually very good reasons for us asking specific questions, and it's to help us get the full picture of what we're seeing in the complaint or the concern that we've heard about or that we're seeing in the marketplace. We have the power to examine licensees, so we can actually review agent records, their financial records that they're maintaining within their agency or wherever their place of business is. We're making sure that they're handling information correctly. So if they have personally identifiable information, are they taking measures to keep that safe? And ultimately, we can stand in the shoes of an insurer when they are going insolvent or have been determined to be insolvent. So we can help, the terms are rehabilitate or liquidate the insurance companies. In those instances, we're dealing both with our administrative courts as well as the civil courts and making sure that the priority of claims get handled. Next slide. So how we do this is really through our statutes and our rules. This is our framework from which we work. So our statutes lie between the 600 and 655, primarily of the Wisconsin statutes. The commissioner's duties are spelled out within Chapter 601. Those entities that we regulate are identified in the beginning 600 chapter. We're looking to find a balance. So we don't want to be so heavy-handed with insurers that they fail to thrive, because then there's no choices available for consumers when they are looking for insurance products. We also cannot just respond to the legislative demands, and we need to balance their intent versus the words that they actually promulgate. And we have to make sure that our consumers are safe, but we're not really advocating for consumers. We're just trying to advocate for the correct outcome. And if you've been in a hearing with me, you have often heard me say that when I make people equally unhappy with me, then I have done a good job. Because if my rule that I'm promulgating is not so biased towards consumers or so biased towards insurers or too biased, in furthering the legislative intent, then I'm going to topple my three-legged stool. But when I keep them in balance, and that way everyone has been heard, and that the regulation, to the best of our ability, is fair to all parties that are affected by it, then we have done an effective job of regulating or issuing that rule. One of the ultimate goals that we have is to not get in the way of people's right and freedom to contract. And that is what an insurance policy between you and an insurer is. It's a contract, or between an employer and an insurer. And we want that landscape to be fair and open so that consumers can choose and have choices of different insurance products of all ranges, all lines of insurance. And the whole principle behind our block of statutes is to maintain a level playing field. So again, we can't be biased towards one line of insurance over another. Our regulations have to be fair and equal across all of the lines of insurance, so that people have options and choices to make literally a free marketplace for allowing the exchange of and purchase of insurance. That said, though, it must be done within some guardrails, and that's where our statutes and rules come in. So we do that through oversight of licensing. When you do a licensing process, we're looking at your financials, we're looking at your background. What we're really looking for is to make sure that you are competent and trustworthy. Do you have a history that directly relates to an issue that we might see in your role as a licensee? We want to be sure that everyone, not just our companies, but consumers, are financially solvent. There is a tendency for those who may be struggling financially, or companies struggling financially, to have kind of an adverse interest in trying to rectify that financial situation. What we don't want is those licensees to use a sale of an insurance product or sales tactics to increase their profit while potentially harming or risking the consumers. We want to make sure that marketing is done fairly, that what is being represented is accurate, and that they're not making promises that they're not actually going to keep, or that the policy wouldn't actually provide for. And again, insurance is a contract. So it's no different than when you're renting a home, or if you're purchasing a home, or if you're buying equipment and you're entering into an agreement. Insurance is an agreement. You are giving something in return for some coverage. And so we want to be sure that that's clear and understandable and fair to the parties. So the statutes and regulations that pertain, what we did do for navigators and assisters is create a study guide that are more specific and honed in on the totality of our statutes and regulations for those that would be applicable and most likely to be touched by navigators and assisters. And so that is on a website that I believe Shelley is going to walk through shortly, or tomorrow. And in it's a great place to go to when you're studying. So I assume Shannon's going to use that with her studying classes on Friday. But when you go to that website, it has an actual guide that we've prepared for helping you do the test that's coming. Next slide. So the start of where a lot of our power and authority rests is in Wisconsin Statute 601.01, and it lays out what we're intended to do as the Commissioner of Insurance. Again, we're to ensure the financial solvency of all insurers doing business in the state, not just the ones that are licensed as domestics in our state, but those who are also doing business in our state. We want to ensure that policyholders and claimants and insurers are treated fairly and equitably. We want to ensure that the state has an adequate and healthy insurance market characterized by competitive conditions and the exercise of initiative. So we want to, what that means is we want to be sure you have a choice. It's nice when you can choose who your insurance is and you get an option of at least two. But also we want those companies to be willing to try new products. The world is not the same as it was in 1870. There's lots of new things happening and lots of risks that never existed even 5 years ago. So we want to encourage companies to stay current and to have products that are responsive to what's going on in the industry. Cybersecurity is a really good example that is obviously much greater lately. And so new products are starting to come out. We also want to maintain this freedom to contract and a freedom of enterprise so far as it's consistent with the other purposes of the law. So we don't want to have the contracts deviate significantly from what the requirements and protections that are built into the requirements through statute and rule, but we want you to have the ability to have some control and some say. And we want to keep the public informed on insurance matters. So you've noticed we've sent out and increased our media presence through social media as well as our website, but as the federal law. So if you just think of the last 8 months, there's a lot of things that have changed with different federal acts or different actions by the state or by the governor. And any of those that relate to insurance, we have also done some additional information. We may have written some bulletins to provide some additional guidance or information on some of these big laws so that we can break them down into what's the most critical components for those consumers in Wisconsin, for the insurers in Wisconsin, for the licensees who are doing business here. And when you look at that totality of the things that we're trying to balance, we achieve those through a fairly small staff at OCI, but one who are experts in the field. So part of 601 addresses that we are to be some of the leading experts when it comes to insurance. So we have broken down some of our areas into sub lines of insurance. So there'll be life, health and disability, and property and casualty. So within each of those lines of insurance, we have experts. We have our staff that delve deeply into the nuances of each of those types of products, how those policies are working, and then how they interplay with Wisconsin's law. The next slide is so if we see a problem, what do we do? Enforcement. One of the things that I do as an attorney for the office is I can hold hearings. I can issue an order, I can issue a notice of hearing that alleges violations of Wisconsin insurance laws or rules. These hearings are held before administrative law judges through the Department of Hearings and Appeals. We can issue formal guidance like the bulletins I just mentioned. And we can do it also through rules. If I'm doing a hearing, it would be against any licensee or those who are not licensed but doing the business of insurance in our state without a license. So I can even take an action, even though they may not be a licensee, but they're doing something that they should have a license for. Navigators are, and agents helping as assisters, but navigators are licensees. So if there's a concern that we have, we may issue a warning letter, or we could have a hearing. And just like any other licensee, if we start with an order, you always have a right to a hearing. We can issue sanctions, and our sanctions include simply an order to comply. Please respond. We can issue forfeitures, which are fines, and we have parameters in our statutes as to how large of forfeitures those can be. And we can actually order restitution. So oftentimes we're trying to get consumers back into the position they would have been had there not been a problem with the insurance product. For the next slide, please. So we license a broad number of persons, and I'm using person in the, not just as an individual, but also as an entity. So we obviously are licensing insurance companies, both that are licensed and created here under our jurisdiction originally, and those that are licensed in other states, but wishing to do business in our state. We have over 176,000 insurance agents. A lot of them are from out of state doing business in our state, and that has risen exponentially with the use of platforms such as web-based access to insurance, call centers. That's also where some of the concerns arise in misleading materials or people doing a business that actually they're not licensed for, but for which they should be licensed. We have one chapter that you'll want to pay attention to is chapter 628 of the Wisconsin statutes, which has 4 main components. And in that statute, we address the licensing of insurance agents, intermediaries. We are regulating marketing practices. We regulate how or the process of compensating insurance intermediaries, and the license and regulation of navigators and the non-navigator assister entities. The licensing of intermediaries and navigators is concerned solely with the qualifications of the person applying for the license. It's an essential requirement that licensees who are in contact with our consumers be trustworthy and competent. The competence includes basic understanding of fundamental insurance law, as well as practical knowledge concerning the specific statutes and rules and the product that you're selling or advising on. Wisconsin statutes are outlined to define general requirements that intermediaries must follow, or companies, but also things that you should not do. We also regulate how clear and understandable pieces should be. So readability of a policy, which I think all of us would profess they're not readable. They are complex contracts, and that is unfortunately sometimes the sticking point for the balance of readability and the need to express very specific terms of a contract. Next slide. So when do we expect you to get a license versus when can you just be helpful? So a person cannot solicit, and in this case sell, negotiate, sell, or advertise any service as an intermediary in Wisconsin unless that person obtains a license. No person may use the services of another intermediary if they know or should know that the other does not have the license required by law. So if I'm licensed in property and casualty, and I want to have you get a health policy, but I don't have a health license, I can't just hand you off and expect to stay as part of that sale. I can refer you, but then I'm out of that transaction because that's not where my expertise would be. And an insurance contract is valid if it is sold or serviced by an intermediary. So let's say you get caught in something that someone wasn't licensed or wasn't authorized by the carrier. We're still going to look to the insurer to enforce that. And you'll see that in chapters, the citation there is a statutory citation for chapter 628, sub 0.03. So persons, there are a few exemptions for licensing, but they're pretty far and few between, and our scope is pretty broad. Let's go to the next one. So I'm going to give you a couple situations, and this is not necessarily a polling question, but if you wanted to answer in your chat, feel free. A person who is incidentally advising other people about insurance needs and coverages during the normal course of their non-insurance related business, and who receives no direct or indirect compensation on account of the transaction. So you're talking to your neighbor over the fence and they ask you about who you have for your home insurance. And you explain to them about your policy and some of the features that you have. Are you now doing the business of insurance? Do you need to be licensed? What do you think? Anybody want to put something in your chat? Or in the, no, I got one answer. I'll give you another couple seconds. But that is correct. Everybody, you are right. You do not need to be licensed for that. That's a pretty typical, you're going to be talking about this and it's okay. You're not trying to sell anything. You're not getting paid for this. But now a person who's placing insurance, so you're actually going to get a policy out of this for an insurance company on a door-to-door basis. Should that person be licensed? What do you think? Great. Yes, I'm seeing in the Q&A section that yes, that's correct. This person we want to be licensed for a couple reasons. They're actually giving you up what is the result of their interaction with you is actually an insurance contract. It's going to be binding. It is legal, but they may or may not know what they're selling. Also, they're coming to your home, and this is where competence and trustworthiness come in on our side. Is that an appropriate person to be doing that sale? And we do look at people's backgrounds. So let's say you've had an individual who has had a run of inability to pay any of their credit cards. And so they're significantly in debt for whatever reason, but they're upside down on their financials. They also have a history of fighting. Is that someone that you would want walking up to a home of an older adult who may or may not be living alone? Our answer is no. We don't want them handling your information. We don't want them alone with you in a sale of insurance if we feel at any point in time that that person isn't competent or trustworthy. Now take those same actions that happened maybe 20 years ago when this individual was a young teen, and in between they have been exemplary. Yeah, then we're going to be more likely to say, yeah, that's okay. Another situation, a person who advises another about an insurance need and coverage and is compensated by an insurance company or the insured. And I think that one's kind of obvious, but yep, there we go. Great. Thank you everyone for answering in the Q&A. You are all correct. Yes, we want them licensed. If you're going to get compensated from anyone for helping place insurance, we want you licensed. We want you to make sure that that person who's doing that interaction is indeed competent and trustworthy, right? So our next slide, please, is the basic principles of why we have insurance. So part of this is it starts with a risk. Risk for insurance is the uncertainty of a financial loss. Okay. You combine that with risk tolerance. So that's going to be very individual. How much risk are you willing to take on? Some of that financial loss can you handle yourself versus wanting to pay someone else to take on? This is where the risk transfers. So doing the business of insurance is defined as a transference of risk. I'm transferring my lack of tolerance or the level of tolerance I have for an uncertain financial event to an insurance company And my exchange for that is I'm willing to pay them a premium for them to take on that risk. That way I have a more known financial future. It better matches my both ability to tolerate risk. Do I have some money stashed away or have ability to find ways to finance an incident versus I'm very comfortable with risk and I'm willing to just take it and I don't need insurance, right? So you're going to get a full spectrum of people. The overlaying on top of this risk transference and your risk tolerance is what you can afford. So this is where a lot of what sisters are going to be doing in navigators with health in particular. So I'm going to speed up a little bit. Contract law, there's some basics and offer and acceptance. So if I give you premium, you say, here's the policy and the terms, and I give you premium, we have had an offer and an acceptance. And there are some unique pieces about health insurance that we'll be seeing. Insurance contracts are going to apply to the policy sold in Wisconsin. They need to be readable. And when I said that earlier, understand that, I just lost my screen, sorry. There we go. Medicare policy that you would think is going to be something important to be readable is actually around a college level of reading level that we expect. So while it's still fairly, still readily easy to read, it is still a complex document. So we're trying to always balance the need to put in technical terms and the balance for readability and understandability. So that's going to bring us to our first polling slide. Great. An insurance company is bound by the acts of an appointed agent when the agent acts within the scope of their authority, even if they have no actual authority from the company. Is that true or false? And do you have the poll going? There we go. The poll is on your screen to respond. I think Michael's going to hold that open for a little bit.
Yep, we'll hold this open for about 30 seconds more, and then we'll go ahead and shut that down.
Thank you.
We'll give that just another 10 seconds or so. So if you have not had the chance to answer that, please do, and then I will end the poll.
Great. 82% of you have that accurate. It is true. Even if you have not been appointed as with a company, as I mentioned earlier, and you conduct some insurance business, the company is responsible for your acts. That is an accurate response, and good job everyone on answering that. I'm going to hand this now over to Shelley to continue on the next slide.
Good morning. Again, as Shannon noted earlier, my name is Shelley Knorr. I am an insurance examiner, health insurance examiner with the state of Wisconsin. I will be taking it from here. So if we could go to the next slide, please. So continuing on with insurance contracts, there are three particular bullet points here that I'd like to address. The first one is notice a claim. Proof of loss is to be furnished to the insurer as soon as reasonably possible and within 1 year after the time it is required by the policy. An example of this would be a person submitting a prescription cost receipt for something that you had to pick up on, for something you had to pick up while on vacation once you return home. Unless otherwise noted by Wisconsin law, Subject to interest payments, an insurer must promptly pay most insurance claims within 30 days after their receipt. And lastly, what is the legal effect of a mistake in an insurance contract? In most circumstances, unless otherwise provided, general contract law applies to mistakes in insurance contracts. For example, in property insurance, a mistake is designating a person to whom the insurance is payable does not void the policy. Such a mistake does not constitute a defense for the insurance company unless the mistake was due to misrepresentation or concealment by the owner of the property. Next slide, please. What are some examples of unfair claim settlement methods and practices? One example would be the failure to promptly acknowledge pertinent communication with respect to claims arising under insurance policies. Another example is the failure to promptly provide the necessary claims forms, instructions, and reasonable assistance to insureds and claimants. Number 3, the failure to attempt in good faith to effectuate fair and equitable settlements, sorry about that, of claims in which liability has become reasonably clear. And number 4, knowingly misrepresenting to claimants pertinent facts or policy provisions. Each line of insurance has a period of time for the consumer to return a policy without a penalty. Life insurance, for example, is 30 days after the delivery for a full refund to be provided. For health insurance, a policyholder may return an individual health policy within 10 days after receiving it. If the policyholder returns the policy within that 10-day period, the insurance contract is invalid and all payments made under that contract must be refunded. The right to return provision must be printed on or attached to the first page of each individual policy. Although an insurer may cancel a policy for non-payments of premiums, a consumer is entitled to a grace period for the payment of any premium due. During this grace period, coverage does continue. For health insurance policies, it is not less than 7 days for a weekly premium policy, not less than 10 days for a monthly premium policy, and not less than 31 days for any other policies. A consumer should always check their policy to see if their insurer includes a grace period provision. Next slide, please. Some examples of plans that are not regulated by OCI are typical large employers that are primarily governed by the U.S. Department of Labor. But when a state's law or regulation is related to the business of insurance, that state may retain jurisdiction over the pieces of that plan. There are a few self-insured employer plans that fall outside of federal jurisdiction, such as self-insured non-federal plans, governmental plans, and church plans. Labor, union, and employee welfare plans are also governed by the U.S. Department of Labor. Discount plans provide discounts on medical procedures with certain doctors or medical-related costs, such as prescriptions, just like using a coupon at a store. These plans are not health insurance plans in the traditional sense. Medicare Advantage plans is the federal government's version of Medicare EPO. The federal government, Centers for Medicare and Medicaid Services, directly contract with insurers to provide these Medicare benefits. States have negotiated and retained jurisdiction over the agents, though, as they are the licensees involved in the sale. Medicare Part D are the prescription drug plans that are sold separately from Medicare supplement policies or traditional A and B outpatient coverage provided by the feds. Healthcare sharing ministries were the original form of a GoFundMe account. In Wisconsin, There is an exception for members of a denomination or organization that agree to financially support fellow members. The member is required to pay any medical bills first, with certain health needs eligible to be posted in a newsletter for other members then to donate funds to offset that individual's expenses. And lastly, direct care primary is a re-emerging plan from the past, with providers, typically primary care internist or family practitioners, negotiating directly with the consumers. OCI does not monitor these offerings as frequently. The OCI does not monitor these offerings as frequently as there is a component of risk transference. Next slide, please. Some key examples, these are some of the key practices that OCI monitors. Here are some examples of the following. Unfair marketing practices. This includes misrepresentation, restraint of competition, and choice of insurer. Misrepresentation includes omissions, misleadings, and false entries. Restraint of competition includes boycott of an insurer or using intimidation. Choice of insurer includes requiring a purchase of insurance as a condition of a contract not related to insurance. And lastly, home solicitation and sales includes a clear statement of intent to sell insurance. Next slide, please. With regards to marketing method and practices, prospective buyers of disability policy must be provided with clear and unambiguous statements, explanations, advertisements, and written proposals concerning policies that are being offered to them. In INS 3.27 of the Wisconsin Administration Code, there is an outline that addresses the minimum standards and guidelines for the advertising and selling of disability policies. Advertising and representations must be truthful and not misleading, and must accurately describe the policy to which they are applying. Please note that an advertisement means printed as well as oral representations. Advertisements may not directly or indirectly make unfair or incomplete comparisons of policies or benefits. Lastly, advertisements may not falsely or unfairly disparage, discredit, or criticize competitors, their policies, services, or business methods, or competing marketing methods. Please again note that this type of method and practices includes printed and published materials, including the internet and web pages, social media pages, including social networking websites, prepared sales talks, presentations and materials used by intermediaries, and representations made by agents in accordance with these talks and presentations. Next slide, please. So we're on to our next polling question. Which of the following are not considered insurance? Health sharing ministries, self-funded ERISA plans, Medicare Advantage plans, or all of the above? It's a little bit split down the middle, but the correct answer is D, all of the above. Health sharing ministries are not considered insurance, just as much as ERISA or Medicare Advantage plans. So thank you for answering that question, and we'll move on to the next slide, please. Here are some common laws from the federal side of things that impact health insurance. Medicare is a broad program of health insurance designed to assist the nation's elderly to meet hospital, medical, and other health costs. Medicare is available to most individuals 65 years of age and older. The Employee Retirement Income Security Act, or ERISA, is a federal law that sets minimum standards for most voluntary established retirement and health plans in private industry to provide protection for individuals that are in those plans. The Consolidated Omnibus Budget Reconciliation Act, or COBRA, gives workers and their families who lose their health benefits the right to choose to continue group health benefits provided by their group health plan for a limited period of time under certain circumstances, such as voluntary or involuntary job loss, reduction in the hours worked, transition between jobs, death, divorce, and other life events. Qualified individuals may be required to pay the entire premium for coverage. The Mothers Health Protection Act includes important protections for mothers and their newborn children regarding the length of the hospital stay following childbirth. This requires group health plans that offer maternity coverage to pay at least a 48-hour hospital stay following childbirth or 96 hours in the case of a C-section. The Women's Health and Cancer Rights Act of 1998 is a federal law that provides protections to patients who choose to have breast reconstruction in connection with a mastectomy. This law applies generally to both persons covered under group health plans and persons with individual health coverage. HIPAA was developed in 1996 and became part of the Social Security Act. Sorry, I lost my spot there. It assured health insurance portability by eliminating job loss due to pre-existing medical conditions. It reduced healthcare fraud and abuse. It enforced standards for health insurance and guaranteed security and privacy of health information. The Mental Health Parity and Addiction Act prohibits group health plans that offer mental health benefits from imposing more restrictive annual or lifetime limits on spending for mental illness that are imposed on coverage of physical illness. And lastly, the Patient Protection and Affordable Care Act is to ensure that all Americans have access to quality health care that is affordable, and it eliminates the pre-existing clause. Next slide, please. With regards to Medicare, it is a federally funded and regulated program that is under the direction of the U.S. Department of Health and Human Services. As previously noted, it's available to most people age 65 or older, but some under 65 can qualify with certain disabilities. Although folks with end-stage renal disease are eligible for Medicare, there is also a state mandate for the coverage of kidney disease as well. Wisconsin is an exempt state from the federal Medicare supplement program, which I'll explain in the next slide. Medicare Advantage plans is the federal version of the Medicare HMO. Medicare Part D are the prescription drug plans that are sold separately from supplemental insurance or traditional A and B outpatient coverage by the feds. Medicare was never intended to pay 100% of a person's medical bills, but was created to offset medical expenses by providing basic foundations of benefits. Wisconsin is a waived state, which means we provide different kinds of Medicare supplement policies not labeled with letters. Medicare supplement policies in Wisconsin have set minimum comprehensive requirements for supplemental coverage. Individuals have their choice of rider options that must be purchased separately from the base coverage. If a consumer comes to you and states they are being quoted a supplemental plan with a letter name, advise them to make sure that this is a Wisconsin plan being quoted and not one based in another state. Next slide, please. So again, we touched a little bit earlier in this presentation about the timely payment of claims, but this offers a little deeper dive. Insurance companies have the right to ask for additional information or documentation to help assist in adjudicating the claim. They can require the consumer to provide additional information. It could be in the form of doctor's notes, any kind of bills or notes from a healthcare facility as well. Next slide, please. When processing the non-renewal of an insurance policy, the non-renewal reason given must be clear and concise. It also, by state law, must be provided at least 60 days prior to that policy expiration. Reasons that are not acceptable under the definition of clear and concise would be condition of property, damage to vehicle, or simply coverage not offered. Next slide, please. Concerning the timeliness of a notice that is required, you must, this is regarding the cancellation of coverage. So this would be something, maybe a midterm cancellation, which you wouldn't find in health insurance, but this is something you may see more in like a property and casualty setting. But you must minimally be given a 10-day notice. And one thing that was determined by the Court of Appeals in Wisconsin is that the written notice that is sent to the policyholder refers not to the receipt by the policyholder, but to the date the notice was mailed by first-class mail. Next slide, please. OCI wants the problem fixed, obviously, for a consumer or a provider that is having an issue with an insurance company or an insurance agent here in the state of Wisconsin. We do not want to see a problem continue, in addition to making sure the consumer was not harmed or wronged in a situation. Next slide, please. There we go. Thanks, Shannon. So some of the issues that are based as sources of the complaint, they can come from insureds, they can come from agents, and they can come from providers. One thing that OCI will not do is we will not, for the most part, become involved with issues between providers and insurers if it's based on the language in the contract, as insurance law does not give us the authority to do that. Next slide, please. OCI handles complaints involving health, life, and annuity, and property and casualty insurance involving insurance companies and their agents. Some of the examples of these complaints include coverage issues, claims disputes, premium problems, sales misrepresentations, policy cancellations, and refunds of premiums. We send a complaint onto an insurance company or insurance agent, and we allow for a minimum of 25 days for the response to be provided back to us. Wisconsin Open Records Laws was enacted in 1982 and is a series of laws designed to guarantee that the public has access to the public records of the government bodies at all levels. When a consumer or agent or provider files a complaint, that becomes an open record once the complaint is closed. Generally, any person may make an open records request, but there are some restrictions. We make all efforts possible to protect a person's private, financial, and health information. OCI works to establish the facts surrounding a complaint when there are different accounts of what happened, or the fact that there may be he or she type situations. We may not always be able to assist or establish who the right party is in that situation. Next slide, please. On our website, we try to educate consumers prior to submitting a complaint what they can expect from our agency. The company or agent's response should provide us with a clear and detailed picture of the events surrounding the complaint and what, if any, resolution can be provided to assist in the situation. We try to educate consumers on how their insurance policies work that they have with the company. And if we don't have jurisdiction over a matter, we will refer the consumer to the best organization available to handle it. Next, please. What OCI cannot do. We also try to educate consumers upfront in situations that we cannot handle for them. We would advise a consumer to consult with an attorney about any of their specific rights. We cannot make and assist with a medical determination. We are not healthcare providers at OCI. We cannot read a medical chart or a doctor's notes to make an accurate assessment of a situation. Medical necessity is a term in an insurance contract itself, and Wisconsin law does not define medical necessity or mandate criteria that insurers must use to determine it. We cannot assist in determining what a consumer feels is the right amount of money to make them whole again. Self-funded plans are generally under the jurisdiction of the U.S. Department of Labor, and when possible, we will refer a complaint over to them for review and assistance. We must remain a neutral party in all complaints. Unless an insurance law or rule has been violated, we cannot take any action in most cases. Next slide, please. On our website, you will find the most recently released bulletins, as well as any kind of checklist for policy form types prior to being submitted to OCI and approved. There is a link under the Consumers tab on our homepage that provides access to all of our resources and consumer publications. Every year, OCI submits a report to the governor and the legislature providing an overview of the insurance industry, the operations of OCI, and important financial and statistical data on the insurers doing business in Wisconsin. And lastly, in 2019, OCI and Governor Evers launched WisCovered to connect Wisconsinites with free expert help to get healthcare coverage. WisCovered helps put people in touch with assistance via phone from organizations like Covering Wisconsin and the United Ways 211. WisCovered is a result of public-private partnership with the governor in 2019 to help make sure every Wisconsinite has access to the affordable health insurance. And that's the end of my presentation part, Shannon.
Great. Thank you so much, Shelley. We really appreciate the time. I think Julie was going to take one of the questions that we have. We are at 11:17, which is 2 minutes over, but we're okay to stay on if Julie and Shelley, you're okay. And obviously attendees do what you need to do, but we will address the questions in the question and answer right now.
So there was a question about Medicare supplement, and I'm not seeing it in the screen right now, that asks what happens if someone comes with a Medicare supplement question? What are navigators and CACs to do? Medicare supplement plans are insurance and should be, those consumers should be referred to licensed insurance agents to go through the products. I understand that may not feel consumer friendly, but that's when we're kind of drawing a line of assisting in particular on the federal marketplace versus getting in some of our other products. If there's also, you can provide them or send them links to the OCI's website for, we have publications that are really helpful for understanding Medicare and Medicare supplement products. There was a follow-on in the Q&A about why Medicare Advantage. So I'm glad the clarification was written. I did do a long answer on the polling question. Medicare Advantage is said is kind of confusing because technically it is a federal insurance product. And so this is the question. Thank you very much, Shannon. But Med Advantage products are really the A and B components of Medicare, which are dealt with the feds. Insurers are involved just as they are with A and B, but it's not a risk. It's not a risk transference. There's often a requirement if you're eligible for you to get this coverage, especially if you're still in an employed situation. An employer can require you to have at least your A or your B, because then they'll wrap around. But it's not a traditional insurance product because you're not really transferring your risk per se in exchange for the premium or the benefits of the product. I'm not sure if that helped.
Yeah, I think that is helpful. It's sort of like the technical legal definition versus the layman's, like what we'll say, health insurance. So
Yeah, all of
that's
these
useful.
technically have health components. You're correct, Shannon, and that is confusing. And this is where consumers get confused and sometimes get harmed. It may be presented that these health sharing ministries are insurance, or they will have insurance terms and use a lot of language that you would see in a typical insurance policy or in their advertising. But you need to understand that that's not what it actually is. And that's part of our role for oversight when people misrepresent the product. So a true health sharing ministry is literally, as Shelley said, kind of a GoFundMe, because you are responsible for any health claims yourself. If somebody wants to join in, the original thought was faith-based and are offering to help you pay your expenses, that's fine. There's no risk transference there. That's just someone giving you some assistance. But it is not insurance. You're paying a premium, which is also misleading, on top of being responsible for those costs. And we are going to go more into each of these tomorrow when we get into both health insurance and then further into the ACA.
Great. Such a nice lead in. So we hope you all will return tomorrow for the second 2 sessions, which will be hosted by Shelley and, well, hosted by Covering Wisconsin, but your instructors will be Shelley and Julie again. So we'll welcome them back. And we hope everyone joins. So thanks again, Shelley and Julie. We really appreciate the time you took today. I don't see any lingering questions. So type them quick if you have them. Otherwise, if you think of one later today or tonight, you can always bring it back tomorrow. As I shared before, we'll have Shelley and Julie back and we can address any lingering questions from today's session. Okay, we've got one more question. What is the meeting time tomorrow? Okay, so just like today, we assemble at 9 o'clock. Tomorrow is the last day of pre-licensing training. So it will be the last day of training this week. And then we will return the following week, so next week, with the regular conference sessions. So tomorrow is the last day of pre-licensing. I think I heard somebody else want to say something.
At 10 o'clock or 9 o'clock tomorrow?
Oh,
We
did I
have 3 hours tomorrow?
misspeak?
I just want to be sure we do our timing right.
Yeah, I want to go to the conference agenda, which I don't have up right now.
So that will be starting at 9 o'clock tomorrow and will be running until the same time as today. So it should end around 11:15. At 9 o'clock, we have the healthcare coverage session, and then at 10:15, we have the ACA, Navigator, and CAC Part 1 and 2.
So hopefully everyone can see the agenda for tomorrow and nobody is shocked. Any other, maybe there's one more question. Nita, I'll one-on-one answer that question via email. Okay, so thank you, everybody.
Thank you. Have a good day.
Have a good day.